Welcome back, guys. Today we're gonna talk about the esophageal pathologies. First pathology is diffuse esophageal spasm. It is a spontaneous, non-peristaltic, uncoordinated contraction of the esophagus with a normal lower esophageal sphincter pressure. That's the difference between the spasm and the achalasia, because the lower esophageal pressure is high in the achalasia. The patient presents with a dysphagia and angina-like chest pain. Barium swallow reveal cross-screw esophagus. Manometry is diagnostic. Treatment include nitrate for the relaxation of smooth muscle and calcium channel blocker. The second subject we have here is eosinophilic esophagitis. It is an inflammation of the esophagus often in atopic patients. So when we say atopic patient, we mean a patient they have asthma, atopic asthma, or have eczema. So food allergen causing dysphagia and food impaction. Esophageal ring and linar furrows often seen in endoscopy, typically unresponsive to GIT therapy. Esophageal perforation, most commonly iatrogenic following esophageal instrumentation. Non-iatrogenic causes include spontaneous rupture, foreign body ingestion trauma, and malignancy. May present with pneumomediastinum. Pneumomediastinum, as in page A here, that means air in the mediastinum. Here, as you see, this is the air in the mediastinum, this is the aortic arch, and this is the trachea, and this the esophagus. So, esophageal perforation may happen in the distal part of the esophagus, that we call it Borg-Haave syndrome. It's a transmural rupture of esophagus. Also, subcutaneous emphysema may be due to dissecting air, signs including crustus in the neck region or chest wall. Esophageal stricture associated with the causative ingestion, acid reflux, and gastritis. The stricture usually happens secondary to something like esophagitis, when inflammation and accumulation of inflammatory cells in the esophagus and replaced with the fibers, so that become stricture. Also after the endoscopy may causing stricture. The next topic we have is esophageal varices. We spoke about it in last videos. Esophageal varices is dilated mucosal vein, as we see here in B and C picture here. We see the dilated vein here and dilated vein here, also red congested vein that's caused by increased pressure in the portal vein. Here also we can see the dilated vein, the increasing in the portal vein leading to shunts. We have mentioned 3 shunts, one of it the esophageal varices. So it usually happens in the lower third of esophagus secondary to portal hypertension, as we mentioned before. Common enteritis may be source of life-threatening hematemesis. Esophagitis associated with the reflux infection in immunocompromised patients with a candida. It usually came with the white pseudomembrane, and herpes simplex virus type 1 also can cause esophagitis. Also cytomegalovirus can cause esophagitis. Causative ingestion or pill-induced esophagitis like biphosphonates and triglycerin, non-steroidal anti-inflammatory drug, iron, potassium chloride. Gastroesophageal reflux or GERD disease commonly present as a heartburn, regurgitation, dysphagia. May also present as a chronic cough, hoarseness of voice, laryngopharyngeal reflex associated with asthma, transient decrease in lower esophageal tone. That the cause of GERD is relaxation or decrease the lower esophageal pressure that may lead to reflux of gastric acid into the esophagus. We know the esophagus epithelium, it is a square, it is a columnar. When the acid reflected from the stomach back to the esophagus media is usually not acid, lesser acidity than the acidity of the stomach. So this may cause metaplasia of the esophageal epithelium, as we will mention in Barrett's esophagitis in next video. So we have also Mallory-West syndrome. Mallory-West syndrome is a tear in the esophagus. Somebody call it Mallory-West tear or Mallory-West syndrome. It is a tear in or laceration in longitudinal gastroesophageal junction, confined to mucosa and submucosa, just for that, not to the muscularis or serosa or adventitia in other parts of the esophagus, due to severe vomiting, often present with hematemesis, usually found in alcoholic and bulimics. So, here we have another cause for hematemesis. As we mentioned before, esophagitis can come with hematemesis. Also, esophageal varices is the commonest cause for hematemesis in cirrhotic patients. And here we have a Mallory-West syndrome. Mallory-West syndrome is caused by recurrent vomiting as in bulimic, bulimia nervosa, and alcoholic patients. Here we have a Plummer-Vinson syndrome. It's a triad of DIE. DIE, dysphagia, iron deficiency anemia, and esophageal webs. Increase the risk of esophageal cancer, esophageal squamous cell carcinoma may be associated with glossitis. It's just a syndrome. Patient complaining with dysphagia, and we found the esophageal web in the endoscopy with the iron deficiency anemia and CBC. That's the Plummer-Vinson syndrome. It usually came in the U ward with esophageal web and dysphagia and looking for the third of triad. Chest stirring. Chest stirring is usually caused due to acid reflux or chronic acid reflux as in GERD. It is formed as the gastroesophageal junction. Can present with dysphagia. Sclerodermal esophageal dysmotility. It is a part of Crest syndrome. It is a telangiectasia, sclerodactyly, esophageal dysmotility, Raynaud's phenomenon, and calcinosis. So what is the sclerodermal esophageal dysmotility? There is a dysmotility due to decrease in lower esophageal sphincter pressure due to the atrophy of the smooth muscle, causing acid reflux and dysphagia, and leading to structural and Barrett esophagus and aspiration.